Thank you for tuning in to the OSCE Station web lectures. Today, we will be discussing how to take a concise and effective history for respiratory presenting complaints. We will go through the fundamental questions for all respiratory histories first, and then look at specific questions relating to certain presenting complaints. Let's start with a brief overview to history taking. This is the general formula, which should be used in most cases. The first step involves a clear introduction, where you should introduce yourself by using your full name and title, and then confirm their name and date of birth. You should then try and focus on taking a thorough history, exploring the patient's presenting complaint and its history. This should usually take the longest time in the consultation, and at this point, you can also do a quick relevant systems review. The next step in the consultation is to explore the background to the patient's health. Questions here will focus on their past medical history, family history, and social history. The last section of the consultation focuses on a patient's ideas, concerns, and expectations. It's very important to find out these, because this will allow you to find out what the patient wants from the consultation, and will also allow you to address any concerns. Let's go over these sections now in a bit more detail relating to respiratory presenting complaints. Firstly, it's important to start with a clear introduction. You should introduce yourself using your full name, year group, or title. This should be followed by confirming their full name and date of birth. Sometimes students can ask the occupation here from the outset, but this can also be asked later on in the social history. It's really important to do this step thoroughly, not only because it's polite and professional, but it allows you to establish rapport and identify the patient. Also, certain diseases affect certain age groups, and therefore it's important to note and can help lead you to certain differentials. A crucial part of medicine is also about gaining consent and being an ethically sound doctor. Finally, you can ensure the patient's comfortable and not in pain, as this will allow you to take the most effective history. So if they do seem that they are, it's essential to offer and give them analgesia before commencing the history. The main part of the consultation takes the form of inquiring about the presenting complaint. It's really important to start with open questions. For example, what's brought you into hospital today? Or how can I help you today? This allows the patient to speak about what they think is the most important things to say to the doctor about their symptoms. In history taking, we talk about a golden minute, where the doctor or medical student should give the patient up to a minute to speak about their symptoms, until we interrupt them with more closed questions. We can then direct the questions to areas we want and try and pick out important details. The mnemonic Socrates is often used to help guide questions here. Specific questions to ask include the onset of the symptoms, for example, when did the symptoms start, and whether this was a gradual onset or acute onset. We need to be able to know the exact duration of the symptoms. Is it minutes, hours, days, or months? Also, how severe they think it is. Often, you can give the patient a scale, for example, on a scale of 1 to 10, with 10 being the worst pain you've ever experienced, how would you describe your symptoms? When exploring the history of the presenting complaint, it's also important to ask about the general course and evolution of the symptoms, and whether they've been getting worse, improving, or staying the same. If a symptom has increasing frequency of occurrence, this could hint that their symptoms are getting worse, so it's important to ask how often they experience their symptoms. Any factors that trigger or aggravate their symptoms should also be listed, as well as any relieving factors, especially in respiratory disease where, for example, asthma has many triggers. You can end this section asking about any associated features, and then you could use this to lead you to a quick systems review regarding any specific systems you think you could be involved. Red flag symptoms should always be ruled out, and these can be remembered with the mnemonic FLAWS, which stands for fever, lethargy, anorexia, weight loss, and night sweats. So here are the key respiratory presenting complaints you'll come across, And it's really important to rule out other key respiratory symptoms, including sputum production, wheeze, chest pain, and hemoptysis, but also include questions from other systems if they fall under your differential diagnosis. We'll be going over more specific questions for these key respiratory presenting complaints a bit later on. Here's an example of a relevant systems review, which I've highlighted in red, but there are further questions specific to that symptom that need addressing, and we'll come on to these in a bit later. So, the next area of the consultation is much more quick and just requires a few questions to ascertain any major past medical history, which is important to note. In particular here, we're looking for any history of respiratory disease, including TB, pneumonia, a DVT, a pulmonary embolism, asthma or emphysema. We always ask the question, have you ever been to hospital before for anything? And if yes, have you been admitted? And did they need oxygen or inhaled bronchodilators on admission? This will allow us to discern the severity of their symptoms and whether this is a persistent chronic issue or not. As part of the past medical history, you can also ask if they're on any medications or if they were on any, especially an inhaler. We want to know the exact dose and the frequency of their use because it's often a common problem where people have inadequate inhaler technique. Also, many drugs can produce respiratory side effects. For example, you can get a cough from ACE inhibitors, interstitial lung disease from methotrexate or cyclophosphamide, and bronchospasm from beta blockers and NSAIDs. Also, steroids can predispose certain individuals to reactivation of TB. Allergies should always be asked for in any consultation and should be confirmed at the end again. So, a quick travel history is important to take in a respiratory presenting complaint. For example, TB is often contracted from abroad. There's often significant overlap in gastrointestinal presenting complaints. For example, you want to ask about local food they ate, any contact with dirty water, so maybe less relevant for respiratory history. You then want to ask about family history, and in particular, any history of TB in the family, cystic fibrosis, or emphysema. Since TB can be spread to close contacts, so all close family members should be screened for this. And cystic fibrosis is an inherited disorder. Alpha-1 antitrypsin deficiency is also an inherited condition which predisposes you to the development of emphysema. A social history in respiratory presenting complaints is key. Firstly, you definitely need to ask the patient about smoking and alcohol consumption and be able to quantify pack years and units respectively. This is because smoking is the major cause of chronic airflow limitation in lung cancer, and passive smoking is also a risk, so you want to find out if there's exposure at home or work. And alcoholics are also at risk of aspiration pneumonia. Often with children, smoke in the house can be a trigger for their asthma, so it's very important to ask specifically about these two things. Living situation needs to be asked about. For example, pets and their pet antigens can cause asthma, and so can carpeted floors, and these are all triggers which need to be asked about. Bird keeping is a risk factor for extrinsic allergic alveolitis and psittacosis. Activities of daily living need to be assessed because this will allow us to discern the severity of the symptoms by allowing us to see what they are able to do and not do. Occupation is another major question in a respiratory history. We want to ask the patient in detail, what does your job involve? Do you work closely with dust or fumes or vapours? Or have you had any history of exposure to asbestos? That's a very important question to ask about, as it's got close links to many respiratory diseases. Also, further exposure to mouldy hay, humidifiers and air conditioners can result in allergic alveolitis. If a patient's symptoms improve at the weekend or on a holiday, this suggests that there's an occupational cause for their symptoms. The last part of the consultation involves exploring the patient's idea about what they think is going on regarding their symptoms. You should ask the patient about their thoughts to this. It's also important to ask the patient if they have any specific worries regarding their symptoms. Lastly, a good doctor should be able to gain an understanding of what the patient is hoping to achieve from the consultation and address these expectations appropriately. Throughout the history taking, it's really important to summarise back to the patient what they've said, and this both confirms your knowledge is accurate and gives the patient an opportunity to add any missing information. Signposting involves explaining to the patient what you've covered. For example, saying, okay, so we've talked about your symptoms, now I'd like to discuss your past medical history. And signposting throughout the history is a really great way to keep the patient aware of the questions you're about to ask them. And I put this blue box throughout the history because you can address these ideas, concerns and expectations at any point. And it should really be done throughout the consultation. It's up to you to pick up on any signs the patient is displaying, including worry or anxiety or fear about a certain thing. Okay, great. Let's look at 2 common presenting complaints and how our questions lead us and are guided by our differentials. So, firstly, a presenting complaint of a cough. As well as the general questions we've just been over, the important ones to remember are, firstly, the duration of the symptoms. So ask the patient, how long has the cough been going on for? This is because this gives us a massive clue as to what the differentials could be. A cough of recent onset is most likely to be an infective cause, especially if other signs such as fever are present, whereas a chronic cough is most likely to be a number of conditions including asthma, COPD, it could be gastrointestinal reflux, or the use of ACE inhibitors. You then want to ask them about the character of the cough, and especially if there's been a change in character of a chronic cough, as this can indicate a new underlying problem, for example an infection or malignancy. The next question to ask about the cough is whether it's dry or productive, and if they say it's productive, whether they've been coughing up any sputum. If they say yes, then how much would be the next natural question. For example, in bronchiectasis and chronic bronchitis, the cough is productive, whereas the use of ACE inhibitors and reflux cause a dry cough. And also in bronchiectasis, they produce large volumes of sputum. And if a patient's got COPD, they'll produce more sputum than usual if they've got an infective exacerbation. Now there's a few more questions relating to sputum that we need to ask about, and this is the colour and the consistency of the sputum. In bronchiectasis and pneumonia, they will have purulent green or yellowy sputum, whereas asthma sputum is usually yellow too. However, in pulmonary edema, it's pink and frothy, so this can give us a real clue as to what's going on. A lung abscess, however, will produce sputum which is darker and more foul-smelling. The last question linking to sputum is the presence of blood in it, and so you should always ask about hemoptysis, as this is regarded as a suspicion for lung cancer until proven otherwise. As we said earlier, questions about timing are really important, especially in coughs. So, is it worse at night? Is it worse at a certain time of day? For example, asthma and heart failure coughs are often worse at night, whereas smokers' coughs are worse in the morning, and coughs due to reflux are worse after eating and drinking. And a psychogenic cough will disappear during sleep. So lots of clues to be got from when the cough is worse. Coughs can often have triggers, so you need to inquire about pollen, dust and cold air exposure, as these are very common triggers, and this could be associated with asthma. As with most histories, it's really important to rule out any red flag symptoms, to rule out malignancy. So night sweats are very characteristic of TB, but fever can be a feature of a respiratory infection. In order to try and find out the cause of the cough, it's important to go through questions relating to possible differentials. So, for example, you need to ask them, do you have any indigestion, or have you noticed any weight loss? As this will help you figure out what's going on. And you can use all these questions' answers as clues as to build a big picture in your mind of what you think could be going on behind the cause of the cough. Coughs can also be a sign of poorly controlled asthma, so it's really important to take an accurate drug history to find out the exact inhaler prescriptions. Lastly, childhood illness also needs to be asked about, since pneumonia and whooping cough in children can give rise to bronchiectasis later in life. And childhood asthma may also present later in life with a cough. And a progressive cough and sputum from childhood suggests cystic fibrosis. Moving on to the second common presenting complaint of dyspnea, or shortness of breath. It's important to start off by asking them to describe the sensation they feel, as there are many different sensations of breathlessness. So this could be a feeling of being tight-chested, or unable to get their breath, unable to feel from the bottom of their lungs, or it could be a functional disability, such as unable to do an activity. It's important to clarify the course of the breathlessness and the duration, so ask them, does it come on suddenly or gradually? All of these things will help us narrow our differentials. I'm just going to pop the differentials up now so you are aware of what I mean when I say to be guided by your differentials. So at the bottom I've listed all the possible differential diagnoses that could be present from a cough, that could cause a cough. And so in your head you should always be thinking of these differentials as you go through history, and your questions are guided by what you think is going on. Sudden breathlessness makes us think more about inhaled foreign bodies or pneumothorax, or a pulmonary embolism, whereas breathlessness development over a few hours is more likely to be asthma, pneumonia, pulmonary edema, or extrinsic allergic alveolitis. If the dyspnea develops over months and years, this suggests COPD, or fibrosing alveolitis, or a non-respiratory cause, for example anemia. And if they've got chest pain accompanying it, it points to cardiac causes of breathlessness. So it's important to ask this question as it can give us clues as to what we think the differentials could be. It's also really important to accurately assess their functionality and activities they're able to do and unable to do, as this will allow us to see the impact of their symptoms and their severity. For example, how far can you walk, and how has this changed? This will allow you to see whether the underlying cause is static or progressive. Again, here in this history we want to assess triggers to look for an underlying asthma diagnosis. Patients with breathlessness from heart failure characteristically get breathless when they lie down, so ask them, does your breathlessness get worse when you lie down? And if they say yes, you can ask them, do you need to use a certain number of pillows when you go to bed? Because these are all signs of orthopnea, and is a feature of a severe fixed airway obstruction. And the question about pillows allows us to, assess the severity of the condition. Another really key question to ask with this history is, do you wake up in the middle of the night feeling breathless? And this paroxysmal nocturnal dyspnea, as we call it, is characteristic of patients who have pulmonary edema from left ventricular failure, and the patient will also complain of pink frothy sputum. You could also wake up feeling breathless due to obstructive sleep apnea, or asthmatics may develop bronchoconstriction in the night and wake with a wheeze and breathlessness. So this question can help also rule out other differentials. It's important to look for other specific signs in the history. For example, do you have any leg swelling or ankle swelling? Or any unilateral calf swelling? These will rule out right-sided heart failure or a sign of deep vein thrombosis, which are both causes of breathlessness. We want to inquire more about any associated features. For example, an associated wheeze points us to small airways disease. An associated cough points to asthma or infection. An associated systemic illness, for example a headache or fever, points to an infective cause. It's also really important to be aware of the fact that breathlessness can be a presenting feature of an exacerbation of asthma or COPD or cardiac failure. Looking at other presenting complaints. So a wheeze is caused by airflow limitation, and this can be due to many things, including asthma, chronic airways disease, or a foreign body. It's usually an expiratory wheeze, but you can get inspiratory wheezes, and that's called stridal, and that suggests a large airways obstruction. If a patient comes in with chest pain and a wheeze, this could either be a cardiac cause, a respiratory, or musculoskeletal in origin, and so it's important to ask a range of questions to hone in on the right differential. So a chest pain history will be directed using the Socrates questions as discussed earlier, where you talk about site, onset, character, radiation, associated features, timing, anything which exacerbates it, or anything which makes it better. Chest pain due to a respiratory disease is often sharp and exacerbated by deep inspiration or coughing, and it's also commonly localized to one area of the chest. Pleuritic pain is often associated with dyspnea and may be due to a pneumonia, a pulmonary embolism, or pneumothorax. Localized anterior chest pain, accompanied by costochondral junction tenderness, is suggestive of costochondritis. And pain in the shoulder tip indicates irritation of the diaphragmatic pleura. So chest pain presenting complaints could be a wide variety of differentials, and so it's important to ask a wide variety of questions to hone in on what you think could be going on. As we said before, night sweats is characteristic of TB, but could also be a sign of pneumonia and lymphoma, and it's important to be aware of this as it's one of the flaws and one of the red flag symptoms which you've always got to ask about in a respiratory history. So there's a lot of different questions to think about when it comes to different presenting complaints, but the main points to remember are the general structure and the main questions. Remember to rule out the red flags, and just get as much detail as possible about the presenting complaint they come in with, as this should take the longest time in the history. Now in your OSCEs, it's not just about the questions you ask, but the way you communicate effectively. And this is really important and essential because it allows you to develop rapport and trust between you and the patient. And this will ultimately lead to better healthcare outcomes, as they're more likely to divulge in more detail, and they're more likely to be open and honest with you about their symptoms, and maybe things like their alcohol and drug use. Using open questions at the start of each section allows you to sit back and let the patient talk and let them give you as much information as they can. You can then use closed questions to help direct the consultation where you want it to go. It's really important to make interim summaries to check knowledge, and it can help give you time to think about what to say next. Leading questions and multiple questions should be avoided because this can also lead to biased or incorrect information, and often the patient will only answer one of the questions you've asked. Keep the language you use as simple as possible. It seems rather unempathic to use phrases or words that patients don't understand, and they may lose trust or not like your style of communication. Empathy is a really key part of any consultation and will distinguish you into a good doctor. However, it's important to try and find the phrases that work for you. For example, you could say something like, "I'm sorry to hear you've been experiencing these symptoms," or "It sounds like you've had a rough time over the past few months," but you've got to find the phrase which works for you and make it sound genuine. So, this concludes this lecture on taking a respiratory history. I hope you found it a useful revision tool and guide and feel more comfortable about taking a general and focused history. Thank you.